It's 1998, and I'm visiting Lesotho, a southern African country surrounded by South Africa, where I happen to be living at the time. Presidential elections have recently occurred, and people are not happy with the outcomes. I'm in a car with colleagues driving through the capital after a long weekend in the mountains. As we drive, the crowd around us thickens. We see angry expressions on faces in this crowd as people shout at us, and believing that we would pass quickly through, we drove on. In a minute, our car is surrounded. Young men sit down in the road in front of the car. People with cinder blocks pick up the cinder blocks and bring them crashing down on the doors of our car, and a baseball bat crashes the back windshield. We are terrified. Some friendly bystanders on the side of the road beckon us, and we somehow pull off the road. We abandon our car. An ambulance drives through moments after this and drives us to the border with South Africa. Back in Johannesburg, hours after the event, our goal is to stay together, to deal with the shock and the pain of this event, and we try talking, we try alcohol, but the sensation of distress, something like the pain of an incision, actually lingers for days. But I was fortunate. I did not develop a severe anxiety disorder. I was not one of the 1.5 billion people who lives in areas affected by conflict, by fragility, or large-scale organized criminal violence, who are more likely to have been repeatedly exposed to traumatic events. Nor was I someone consistently exposed to the traumas of forced migration or other adversities in childhood, increasing my risk for disorder. I have not lived in settings of deprivation. And to my knowledge, I do not have the hyperactive hippocampal circuitry, that little area in my brain where anxiety and fear arise, that might increase my vulnerability to post-traumatic stress disorder. And I was not a child. This did not happen to me during one of the sensitive periods of development during late childhood or early adolescence, which is the time during which the majority of mental disorders present in adulthood begin to emerge. And I had access to safety, and I had the ability to find resources to manage my own emotions. But childhood trauma is one of the risk factors for mental disorders in adulthood. And mental disorders are common. About 1 billion people around the world live with a mental disorder. That's 16% of the global population. That means about 1 in 6 people are living with a mental disorder. And we think of depression as the most prevalent, but anxiety disorders, schizophrenia, substance use disorders, these affect hundreds of millions of people. Much of my research has focused on people living with severe mental illnesses. And these are conditions that have reached the later stages of illness on this continuum from well-being all the way to lasting symptoms and chronicity. They include things like psychotic disorders or schizophrenia, but also severe bipolar disorder and sometimes severe major depression. They're accompanied often by impaired functioning, sometimes repeated psychiatric hospitalizations, as well as social problems like unemployment, poor social support, and even homelessness. Adults with severe mental illnesses are more likely to have experienced childhood trauma and are also more likely to experience adult victimization. This cumulative exposure to multiple kinds of childhood trauma increases the risk for victimization in adulthood, and high rates of childhood adversity seen among people with severe mental disorders is strongly related to psychiatric problems, including depression, post-traumatic stress disorder, suicidal thinking, as well as repeated psychiatric hospitalization. This has a gender component as well. For women with severe mental illness, violence all too often accompanies relationships with partners and families. 1 in 3 women with severe mental illness experience violence in intimate relationships, And these women experience a 13 to 19-fold greater risk of violence than the general population. And importantly, this has consequences for their mental health and well-being, but also for other significant health risks, like HIV. The global HIV pandemic is one of the most challenging public health problems of our time. For women with severe mental illnesses, the psychosocial context in which they live frequently increases risk for HIV infection. Now, in the United States, you can see that we have a HIV prevalence in the general population of around 0.5%, 0.5%. But there's an estimated 4 to 10-fold difference in HIV prevalence between the general population and people living with severe mental health conditions. But this is a global problem as well. This is not just a United States problem. Among Ugandan women, HIV prevalence is almost twice as high among women with serious mental illness than in the general population. So the solutions to these kinds of problems must also be global. How do we approach complex problems that must address mental health, other medical conditions like HIV, and the social contexts in which they arise? Well, the University of Washington Global Mental Health Program faculty and staff work to do precisely this: to develop, test, build capacity to deliver contextually appropriate and sustainable models for mental health intervention with local and global partners. Because we recognize that addressing the challenges of mental illnesses, whether childhood trauma, or the complexities of depression and HIV, or perinatal mental health, can be done creatively when we work across borders, across cultural contexts, to solve these kinds of problems. In fact, solutions from the global south can be applied in the global north. And this is one example. You're seeing an image of the friendship bench. This intervention, delivered on an ordinary bench instead of in a therapist's office, provides an evidence-based psychological therapy adapted for the delivery by trained community health workers in Zimbabwe, and they're typically grandmas. It's effective in reducing symptoms of depression for people who are living in considerable adversity. The name of the therapy is called problem-solving therapy. It's also being analyzed now for how well it improves adherence to HIV treatment for people who are managing both mental health problems and HIV. Interestingly, New York City has also adopted this and adapted it for use by peers across their boroughs. And the bench has also been sat on by the Duke and Duchess of Cambridge. So imagine when some of the mental health effects of childhood trauma and adversity can be mitigated by non-specialist providers in the global south and in the global north. And imagine if we can actually begin to test some of these innovative global approaches to our comprehensive responses to challenging local problems. And I'll give you just one example. And this is already happening. And this is the beauty of global mental health. Thank you.